the land on which the Fields Institute operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. And I'll turn it over to Zhen Hong now, who will introduce our speaker today. Thank you.
Thank you. Thank you. Good day. And thank you, Nate, for coming to talk to this colloquium and each of you previous lectures in this series has been very inspiring. I thought I don't need to prepare to introduce you. I thought I know you a lot, Professor Osgood, but when I started to think about how to introduce you, I found that it's so comprehensive that let me just only mention that Professor Osgood is primarily in the Department of Computer Science at the University of Saskatchewan, but he is being associated with many different academic units, both within the university, within Canada, and internationally. And Nathan is playing a very important role in the province to linking different stakeholders together using mathematical and computational technologies, and he is a major force driving to develop of national capacity of mathematics for public health. So with that, Nate, it's your time.
Thank you so much, Zhen Hong and Benjamin and Zara, for the opportunity to speak and for your kind words. It's really an honor to be with you here, and very exciting in many ways to share with you some of the background and findings related to long COVID or post-COVID conditions. Now, I will say at the outset that this talk serves several roles. One of them is to review the evidence base for, I recognize that many modelers are coming to a very rapidly changing landscape for post-COVID conditions, and I'm going to be substantiating an understanding of what those conditions look like here in Canada, at the same time as I seek to puncture a number of prevalent myths involving long COVID or post-COVID conditions. Myths, some of which circulate in sundry areas of the social media landscape, but others of which sort of benighted me when I first started working in this area. Sort of misunderstandings or oversimplifications of the situation. And as I've gotten more into the area over the past 2.5 years, I've recognized that many other, carry some of the same misconceptions. I'm further going to be using this as an opportunity to give glimpses of some of our work together with some really formative and foundational reports recently contributed out of Statistics Canada and Public Health Agency of Canada, together with the Canadian Immunity Task Force, that can serve as real important sources of data for modelers. Now, I'm going to weave together, per the title, this kind of patient-centric view of this area. I'm going to weave together quantitative side with qualitative voices, drawing on the focus groups conducted as a component of our work. And all of this is going to lead up to a brief look at some of the modeling we're conducting, both with machine learning models, the unreasonable effectiveness of very simple models in this area, and then some dynamic modeling with agent-based models, 4 of which we've built. And subsequently, I'll offer some closing remarks. When I first presented sort of a subset of this work, a component of this work last fall, we agreed that probably it was going to fill one of these colloquium sessions to the brim. And so I have to apologize to the organizers and, most importantly, to the participants here, the audience, for the likelihood that I'll take all of the hour and maybe a bit some. And I'm glad to have discussion of these materials after the hour if people want to participate and can stay around. But I do have to apologize for needing to lead you through kind of a very large amount of material in a comparatively short time. So I noted I want to go through a set of myths here, and I'm going to be coming back to this set of myths, not with the assumption that any of these are necessarily in your minds, but they are myths that circulate out there. Again, whether in amongst fellow modelers or in areas of the social media landscape. But I want to step back and just observe that pandemics over time, the polio pandemic, the Spanish influenza epidemic, following the Ebola outbreaks in the mid 2014 era, these have all been followed by sort of long tails, long impacts. And early on in 2020, it was recognized that COVID-19 was likely going in this direction. And the evidence built up and led to some alarming headlines in various prominent forums to the effect that we may be dealing with the emergence of a new major chronic disease. And unfortunately, those warnings proved prescient. I'm going to use a number of terms here, and I want to be a little bit specific about what we're referring to. So symptoms that persist or arise following COVID-19 infection after 4 weeks of infection are sometimes grouped into two bins. Ongoing symptomatic COVID, which is really often considered 4 to 12 weeks, and then post-COVID syndromes or post-acute sequelae of COVID. Goes by various different names, post-COVID conditions, which I'm going to refer to as beyond 12 weeks after the original infection. So that's 3 months. And I'll use the term long COVID sometimes in here, and I hope you'll forgive me for it. It kind of includes both of these, but a lot of my comments will be specific to the post-acute sequelae of COVID or PSC. Yeah. I'm going to draw on a number of sources here. One of them is a fantastic new set of representative samples conducted by PHEC, StatsCan, and Canadian Immunity Task Force, the first element of which was released in the fall, this past fall, and then a new report just released in late March, which goes into more detail on a lot of the breakdowns. And many of my visuals are from these two sources that I'm going to be weaving in together with our own work. Our own work consists of longitudinal smartphone-based data collection, started in February 2022, but it also includes focus groups from the same subset of those participants, and I'll mention more about those later. Some custom apps related to the Ethica app that came out of our lab, and studies specifically look at shortness of breath and on the immunological level together with Vito Intervac here at the University of Saskatchewan. The surveys will of these areas be perhaps most prominent, together with the voices of people from this focus group area. And the survey has a number of components. Very importantly, questions about presence and absence and the severity, if present, of a variety of symptoms. And this is collected over time. So on a monthly basis, by default, these surveys are triggered. People can proactively indicate things. And this is with our Ethica data platform that came out of our lab together with a neighboring lab about a decade ago or more, and was has now served hundreds of studies worldwide with a configurable health platform for HIPAA and GDPR, so the European data privacy standards for collecting health data, including sensor-based data and questionnaires. And we're leveraging that platform for the data collection. It includes a variety of surveys, 3 main ones: a baseline or intake survey, a follow-up survey, and a survey for proactively reporting symptoms, and as a whole administrative side to it that's very refined now. I want to talk about these focus groups, though, because this is really where patient voices come through. They help us understand why we see certain patterns in the data. They help us tell us the human side behind that, the stories behind that. And basically, there was a set of focus groups that drew on people from 8 Canadian provinces, with somewhere over 40 individuals, and discussions were had. And then there was thematic analysis conducted with NVivo, and then we grouped their comments from the transcripts into a set of themes. So I'd like to jump into some background on long COVID while working to puncture these myths. So the overall prevalence of long COVID or post-COVID conditions in Canada is estimated to be about 15% roughly of infections. And so that's afflicted now 1.4 million Canadians, or 4.6% of Canadian adults. And by age, the differences are fairly muted, but one sees really big disparities once one looks at birth sex, with females having much higher rates than males. When one looks socioeconomically, those who have less than a high school of education are really disproportionately hit hard. And other vulnerable groups, such as LGBTQ community, also very, very hard hit by the occurrence of these longer symptoms, these post-COVID conditions following infection. And this is something we see in our data from the smartphone-based study when we look at not just presence or absence, but severity of symptoms. It turns out females, you notice the darker lines here indicating higher level of severity. This is not merely a matter of self-reporting and more willingness to admit a bad condition, but it is consistent with other indicators of presence, absence, etc. Similarly, for individuals with other risk factors, things like different levels of overweight, for example, disabled individuals, we're really seeing very high burdens in groups that are vulnerable in our society, groups whose navigation of the healthcare system, say for disabled people, is particularly challenging. And I want to bring home the fact that long COVID is sometimes misconstrued as, you know, a condition that afflicts people of time to worry about, you know, nuisances and not people struggling with really big conditions. And the evidence we see really clearly shows it has very, very high burden on communities which are vulnerable in other areas. Those subject, for example, to high rates of infection. And as I'll talk about later in this presentation, we're working with Métis Nation of Saskatchewan to roll out a version of our study to their 80,000 members in reflection of the very high burden seen in Indigenous communities. So if you consider the high rates of infection and the high rates of adverse symptomology, particularly severe symptomology in vulnerable communities, it translates into long COVID burden. Also following issues involving limited access to vaccines or limited trust with the system. Now, I'll come back to some of these points, but it's, you know, this is not a condition which is one of people who have the luxury of medicalizing slight symptoms, not at all, as sometimes comes up as a misunderstanding. It is a condition that manifests in a dizzying array of different areas, in different areas of the body. It's been implicated for over 200 symptoms. But these symptoms, while they can be quantified as to greater likelihood of occurring, well above the levels seen in control groups, as shown from this very substantive study with over 150,000 individuals. these symptoms manifest here in Canada in some very high burden ways, such as very high rates of fatigue, coughing, shortness of breath, and brain fog, and other symptoms among those infected by COVID. But it's not merely symptoms here; it's complications. Another graphic I was thinking about showing was some work by Iwasaki from Yale and others, really noting how symptoms are often have their mirror in complications which arise. So shortness of breath, for example, in pneumonia. And we're dealing here with complications, pathology that exists across many organ systems. These burdens are collectively can be of staggering size, and they can follow up with neurologic sequelae. Recent work suggests acceleration of dementia, early stage dementia, for example, in individuals infected with COVID-19 is quite likely as an aspect of post-COVID conditions. Worsened dysglycemia, this from a US CDC study showing newly diagnosed diabetes among those infected by COVID, not merely because they get found because they're finally seeing a physician and otherwise would have flown under the radar, but it seems to be a causative component driving forward diabetes. Immunological dysfunction in terms of dysregulation of the immune system, and very troublingly, marked mortality differentials associated with cardiac outcomes, which suggest that those with severe COVID-19 in the year following their infection have a markedly lower survival probability in that year following, their acute phase of COVID. This is not during their acute phase of COVID. This is the year after that, having much lower survival rates. This is a burden which is felt, casts a long shadow that can affect mortality. So there's an idea that, that the primary burden of long COVID is bearing with the symptoms. And indeed, that is a staggering burden, as we'll see. And I don't want to minimize that across all these organ systems. But another side of it that is less talked about is the big mortality burden in the year following infection. Now, I want to address this notion that long COVID or post-COVID conditions, people sometimes think of it as kind of a monolithic condition, or alternatively think of it as kind of totally scattershot, totally with no sort of clear pattern or structure to it. And neither of them are true. Long COVID or post-COVID conditions seems to manifest in a set of different endotypes. And there's a lot of debate about what these endotypes are, but some good candidates for them are showing here. Ones that are more based on inflammatory responses, ones based on post-intensive care things. If you've been given a tracheotomy or you've been given pump full of steroids in the hospital, you're going to have long-term symptoms from that. You may have organ damage, fibrosis in your lungs, etc., from very acute COVID shortly after infection that also casts a long shadow. But there's this postural orthostatic tachycardiac syndrome. There's impacts on GI function as well that are notable. And we're still trying to probe what are these underlying endotypes, but there seems to be a large amount of structure there. It's not that these, it's all monolithic, far from it. They're these separate subtypes, but neither is it, just willy-nilly scattershot, whatever comes. There's a lot of covariation. And if you look from our smartphone-based study at how people report severity of different symptoms, those who report severity high on one axis, so along these columns, a greater severity for depression, for example, be going from here to here. And here, along the rows, a greater severity would be going upwards. And so what this is saying, for example, is depression and headaches have a large amount of covariation, or anxiety and brain fog have people who report high brain fog tend to report higher anxiety as well, higher fatigue as well. Now, it's not that everything is codependent on everything else. Actually, you'll find, for example, rashes and loss of smell as comparatively little correlated with, for example, heart palpitations or pain or cough now, etc. But if you look at a diagram like this, and any data scientists among you in the audience or others used to working with data will probably be thinking about, let's figure out the salient patterns of covariation here. And of course, one of the most basic tools for this, a tool hampered by linearity assumptions and others, is the principal components analysis. And in a simple use of principal components on these sort of symptom severities here will reveal striking underlying patterns of covariation that are distinct among these conditions. The first principal component of this data in a study, for example, explains 40% of the variation among these 25 symptoms. So among these 25 symptoms, each of them has some severity for a given person, but with a single number, you can characterize 40% of that variability you see across people with a single number. That's sort of the most salient number. The next principal component will explain another 7.5%, and the next one yet about 6.3%. So collectively, you're talking there, right? A good 53, 54% of the variability being explained by just three numbers for a person. Give me three numbers and I can characterize their level of severity, for example, across these 25 symptoms with capturing over half the variance. And these patterns of covariation, these principal components, capture kind of sensible things. For example, mental, psychiatric, and affective ones are commonly associated with principal component 3. If you look at all long COVID individuals, or could be in 4th if you look at mild separate from severe. Respiratory and cardiac ones, principal component 2, and sort of a group of fatigue and brain fog for the first. Plotting individuals in principal component space, kind of with this natural coordinate system, we can look at how they differ from each other. I'd have to double check it for sure, but I believe these individuals are the individuals who are essentially not infected with COVID. And then what you have is a successive kind of cascade from mild individuals to moderate individuals to severe individuals, occupying different areas of this space. There's a lot of structure here, in other words. This may look, 25 symptoms, people have a different grab bag set of these, but actually, if you look more deeply, just 3 numbers will get you the bulk of what you need to characterize a given individual. Now, one of the most salient factors for understanding that is actually the acute phase severity. And I have to be careful because we're talking here about severity with respect to symptoms they're experiencing now in the long COVID phase, as picked up with the smartphones. But now I'm talking about what was their severity during the acute phase after they got infected. That was also indicated here. Now that severity turns out to really be quite predictive, not totally determinative, but quite predictive of the occurrence of these post-COVID conditions. So among those who are hospitalized, for example, over 40%, that's from the PHEC StatsCan CITF data, over 40% developed long-term symptoms. With those with mild, it's not zero, but it's about 7% who develop longer term symptoms. We'll come back to this, but you could see there's kind of a gradient here, and that's exactly what we see here reflected when we look at these outcomes. We see it very much in our data with symptom severity as you go this way from no to moderate to no to mild to moderate to severe or critical. You see this successive burden indicated across these dozens of different symptoms in terms of the severity of those symptoms. Okay, so let's talk about some other components though that are important for a health equity standpoint to understand, and which are valuable for prediction. We'll come to our machine learning models which use these, etc. If we look at the occurrence of long-term symptoms among those infected by COVID in Canada, and we consider what fraction of those, say, with chronic lung conditions develop these post-COVID conditions versus those with asthma versus those with chronic heart disease, we do see some variability, but there's quite big error bars here, you'll notice, in terms of this. So there's a lot of overlap in terms of trying to detect statistically significant differences. But work out of the Institute for Systems Biology, fantastic work that's described in this Cell paper by Jim Heath and others, have identified four major predictors, including diabetes, female status, unfortunately, for birth sex, and also Epstein-Barr virus infection, and sort of an original antigenic sin, previous signs of previous coronavirus infection, pre-COVID-19. There seems to be a predictive role there in terms of a person's history. Those four things can predict a lot. If we look at not individual one of these, but a count, it turns out to be highly predictive. If we look at the count of underlying conditions, pre-existing conditions that someone had, those with 4+ symptoms have a risk of developing post-COVID conditions following infection that dwarfs those with none or with one. That's not to say that healthy people don't develop long COVID. They do, and in spades, and it can be debilitating. We've heard it so much in our focus groups, and we see it in the data. But the risk is much higher for those individuals under the burden of many pre-existing chronic diseases. How heavy is this burden? There's sometimes this notion, again, that it's a nuisance. It's, people talk about a bit of hair falling out or loss of smell or taste. A nuisance, to be sure, but maybe not life-threatening. Well, it turns out it's really high burden in many people. And if you look here from the StatsCan PHEC CITF study, how often daily activities were limited, those reporting often and always are collectively, about 21.3% of the individuals who develop post-COVID conditions. That's a pretty sobering thing if their daily activities are limited, and we'll see it can be for a long time. In our smartphone-based study, we see the same thing, and there's a gradient again. So among those who had severe to critical chronic infection, disproportionately common in low SES communities and indigenous communities, individuals with who are struggling with other chronic conditions, we see quite a risk of not being able to perform all activities or even not caring for themselves. Whereas those with mild to no symptoms, well, some of them cannot perform all activities, but by and large, most reduce or avoid activity. That's still pretty bad, or a very low level of limitations. To give you a flavor of these, let's hear from some patient voices. It would take me an hour to walk up the flight of stairs and back down because I was so short of breath. I could do a kid's puzzle for 15 minutes and I have to rest for 14 hours, right? Or getting up, this is postural orthostatic tachycardic syndrome. It sounds like, the blood pressure drops and the person is nauseated and gets dizzy. So these are some very high burden symptoms. And once again, it emphasizes that, together with things like new diabetes or heart damage or neurologic damage and acceleration of dementia, these can be life-changing factors. Fortunately, there's very good evidence now that that vaccination seems to play some protective role in two ways. The first of them much more strongly evidenced than the second. The number of doses received prior to infection, as you'll see, there's a strong association. The more doses you've received the vaccine, the lower the number of people, the fraction of people reporting long-term symptoms following infection. And some studies have looked at this, across many particular spheres of symptoms and demonstrated similar effect. It's not that the risk of long COVID disappears at all. No. It stays, and breakthrough infection can still be present, but it does seem it tends to lead to fewer symptoms and shorter symptoms, according to some of the literature. Now, I want to highlight, though, that there's some less widely substantiated, but still tantalizing evidence. Several lines of work out of France and out of the US that do suggest vaccination following infection, not before, that's what these were, prior to infection, but following infection may have a prophylactic impact on heading off the risk of post-COVID conditions, or lessening that, really. And I shouldn't say head off, but lessening the duration and the count. So that means, administering a vaccine after someone has been infected. Maybe they presented with a strong dose. The evidence of this, is more limited, and we have to interpret it very cautiously with a big asterisk. But it is tantalizing, and it may suggest, some avenues in a field where we're really limited with therapeutic options right now. We do see reductions in risk over time of the fraction of individuals here in Canada presenting with long-term symptoms. And some part of this is likely due to Omicron. Notice, contrary to some myths, Omicron hasn't eliminated risk of long COVID. It is lessened, it seems, with Omicron. Studies seem to bear that out, but it's far from eliminated. But one also has to temper one's understanding of this lower risk over time as one heads into Omicron territory, with an understanding that most of the infection, all the infections here essentially, and many of them here, probably most here, were in the context of no vaccination protection. So that's one of the reasons it decreased. How long do these symptoms last? They can last a long time. In our focus groups, some of the individuals were reporting symptoms lasting upwards of 2 years. Someone had gotten infected in early months in 2020. And we see that in some of the data too. So, nearly half of those who are more than a year since their infection, over half who have post-COVID conditions have had it for over a year, or for over a year, almost half of it, 47.3. So these high burden conditions in many people, these conditions that are high burden in many people, can stick around. And, there's a very real risk here that, as my colleague Donna Goodrich is wont to emphasize, that, this persistent disability, including of individuals who are younger now, is a really troubling prospect, with it have the prospect of lasting decades. That much of their life is overshadowed by this. I want to highlight some intriguing things from our study that are more preliminary, but, and forgive me for the crude visuals here, but one thing we see goes against this myth, and that this is a matter of symptoms that merely originate in acute phase and then resolve over time. There is a big component of that, but it seems that some symptoms originate after the immediate period following infection. It's not just, we get a cough and it takes a while to go away, or we get brain fog early on, it takes a while to go away. Some symptoms seem to come up later. You actually see a rise, it seems, in the symptom count in the months following the infection. Some part of that is depression over time. And again, this is very preliminary stuff, but depression seems to be one of those factors that itself is worsened by the high burden of the condition and manifests not immediately. One doesn't often develop depression while acutely afflicted by COVID infection, but rather in the ensuing months. And there seem to be other of these symptoms and damage that occurs, these complications, certainly development of diabetes, for example, or damage neurologically, which seem to, substantially manifest as pathologies later. And this is manifested in people's comments and the voices of patients. It cycles. They cite this non-monotonic. It's not just going down over time. You're waiting to get rid of it. It comes, it flares up. It has these, sudden bursts, and then might work to abate, and then might flare up again. And one of the more troubling components of this, and important for us as modelers, is the cumulative impact of reinfection risk that's suggested by this work from the VA in the States by this towering author, Ziad Al-Ali, that's published on this, citing, with multiple infections, how with each successive infection, the risk rises. It's not that, having been infected, you're then inured. You had that risk your first infection, but after that, you're pretty well protected. It seems that it rises with each subsequent infection, which is sobering indeed, as I'm sure all the modelers are thinking. Now, I want to address a final comment that has a really human side to it, and it has to do with final myth having to do with the fact that we can tie up an understanding of long COVID with a bow based on data from electronic health records and administrative databases. Were it only so, it turns out that the patients with long COVID are really struggling, and I'd recommend this article by Brown et al., as well as a paper soon to come out in CMAJ Open by my colleague Donna Goodridge, describing some of these patient voices I'll be quoting in a minute. But patients are really struggling here. And we see it in the data from the quantitative study in terms of the fraction that seek care, for many conditions less than half, and their satisfaction with care. They ain't getting no satisfaction in many cases. There's real gaps between what they're seeking care-wise, their needs, and what the health system right now is able to provide. And the evidence is that people are falling through the cracks here. It's not merely a matter, this is a new condition, there's no coding standards that are established about it. The ICD-9 codes, or ICD-10 or 11 codes that I believe are not yet established. If so, it's very, very recent. There's doctors who are still learning about this. All that is going on, but the energy level to pursue this for someone with long COVID is often not there. And so while it's challenging for the best of us to navigate a healthcare system, for someone with long COVID, the burden can be crushing. And unfortunately, often they're shunted, into buckets, into pigeonholes, and told, okay, you need antidepressants, or you need, you need to take this for your cough, and not really provided sustained whole person care that deals with the different symptoms. The healthcare system is a disease care system set up to deal with different diseases on a specialist basis, but that interdisciplinary care for long COVID is just now coming into being in these clinics that have been set up only very recently. And you hear it in the patient voices. Physicians here are just not equipped to deal with this. And you hear people praising you're bearing with it, but people are feeling alone, and they don't have the energy often to be their own advocate. They lack the ability to remember and articulate some of the symptoms that they're going through, and to communicate them effectively to a dizzying array of physicians that they have to see about each of those organ systems separately. So, the real risk here, is that while it would be very desirable if EHRs, electronic health records, and administrative data were adequately capturing these patterns of burden. We're capturing those with long COVID. There's such struggles going on to motivate, to get up the energy to seek care, or to continue seeking care, when there's often just discoordination within the healthcare system, that we're in a situation where likely a lot of the burden lies hidden from these databases for now. We're hoping to do better. I'm working with our group towards setting up, harmonizing our data with a long COVID registry that we hope will unite patients across Canada, et cetera. But, we're very early in an uphill battle there. I want to talk some about the analytics conducted on this with this group. And I only have a few minutes to highlight some very promising lines of work here. One is prognostic machine learning models. Really looking at, from the point of view of patient care, very early on in, at the time of initial COVID infection, when a person's severity of acute infection is known. Their age, their sex, their background conditions, that basic information. For example, to what degree can we predict they'll be likely to develop long COVID, or develop particular high burden long COVID, or certain particular outcomes, such as occurrence of psychiatric outcomes. If we could identify these, we could potentially line up support. We could have close monitoring, watchful waiting in place to provide them the support needed on an ongoing basis, which could help triage in a context where the medical system is overwhelmed, where we're always at high tide in terms of the volume of infections, to quote a recent article. And here there's kind of this surprising effectiveness, or if I'm to sort of adopt a famous title of a famous paper, an unreasonable effectiveness of even very parsimonious predictive models. We've evaluated a variety of models, and I need to cite my student Wenjing Zhang for her leading role in this, and Amanda Zimmerman before that. I've just shown three that Wenjing recently ran, and what I'm going to highlight here are results that are not the best we've seen by any means, but are based on 4 variables. So I showed that hidden structure before between different symptom severities. And what I'm showing here is that, just 4 pieces of information: sex, vaccination status, acute severity, how acute severe they were in the acute phase, and the count of pre-existing conditions. You can get an F1 score upwards of 75%, which is pretty decent, 0.75, and an AUC, an area under the curve, of over 0.8. which is pretty decent. We can do better, of course, with more variables, but even just like there, even just a few numbers could tell us a lot about one patient. A few numbers here can let us anticipate a lot of where a given patient will go. And I chose to emphasize kind of the most simple model, recognizing that, it's not terribly impressive, but it's a lot better than random guessing. It's actually quite informative, quite predictive compared to just guesswork. I want to talk though about our long COVID dynamic modeling. This work started over 2 years ago with our ABM used successively in Saskatchewan, Yukon, and then in the Australia Capital Territory, which is still in use for a health system. It's an internal model built by our lab and then continued by Kurt Kruger. But in the summer of 2021, a module was added there for long COVID to try to understand as best we could from the early evidence there how big a burden it would impose, and where it would come out in terms of need for specialist care, interdisciplinary, or self-care. Subsequently, and Nastaran Jamali is sort of the lead of this, we've worked on a more long COVID specific model, which really goes in and captures some of those patterns we've seen and looks at disappearance of different symptoms over time with an eye towards comparing it with what we get from our smartphone-based studies. I also have separate work that I won't expand on, but which is really exciting, that Ellen Rafferty is helping to lead. We're providing modeling support for the Institute for Health Economics, as well as for the Workers' Compensation Board in Alberta. Some really quite exciting work. And finally, there's some work Nastaran has been undertaking jointly with the RJ Adjunct group at PHAC. Again, an ABM. All of these are all ABMs. This is a sort of simple ABM, as is that work with PHAC. Maybe I'll provide just a glimpse of this long COVID ABM, bearing in mind that we're coming due for time very quickly here. So this long COVID ABM has a variety of features. It has kind of infection pathways where we have people, presenting with pre-symptomatic, proceeding on to mild or moderate symptomology or potentially severe, and then we have the presence of vaccination and other factors. Now, for each patient here, we have some characterization of their symptoms, where recently we've added some use of those principal components we identified, giving the covariation between symptoms or our presence absence of symptoms, which I didn't show, to characterize for a given patient, what symptoms do they have? So rather than viewing each symptom as kind of an independent matter, rolling the dice independently for each, we instead use these principal components to sort of capture the covariation between symptoms. People who have brain fog will tend to have, for example, fatigue, and we can capture that covariation with those principal components I talked about earlier. This allows us, we actually have kind of for each agent, a population of symptoms that they have, each of which can have a level of severity, a diagnosis status, treatment pathways, separate timing of resolution, and whether it's active or inactive. Now, for certain of these, that population of health conditions for a given patient, so a given patient may have 8 health conditions that they're dealing with, 8 of these post-COVID conditions. And some of those are distinguished by bespoke structure that captures their particular their particulars of their progression. For example, diabetes. Remember back to that CDC study where they found a troubling number of new cases of diabetes seemingly pushed over from lower levels of dysglycemia into outright frank diabetes, type 2 diabetes, pushed over there by COVID infection. And here we have special structure, right? Because if someone develops diabetes, outright frank type 2 diabetes, perhaps with compromises to their pancreatic mass and function, they're not going to be able to just go back to a non-diabetic state or pre-diabetic state. It's a one-way trip. Similar with cardiovascular damage extending. So we have some of these symptoms captured on a bespoke basis, a fashion that captures the particular distinctions and the aspects of progression that are unique to that symptom to capture, say, the occurrence of permanent pathology, permanent scarring or damage. Think also lung fibrosis, for example. And then we can capture some history information on agents because of agent histories. So for example, diabetes state charts here, we have diabetes with complications, without, etc. In the future, we may modify this for microvascular and macrovascular complications per much of our diabetes work in the past. But here we have a special structure. So this model is allowing us to explore the impacts of different vaccination strategies, or the impacts of different COVID prevention strategies, for example, recognizing, for example, the vaccination might make less likely both infection, severity following infection, and conditional on that, the less likelihood, reduced likelihood of post-COVID conditions. So we can capture at an agent level some of these outcomes. And this is model early in its development, but Nastaran has been taking it forward, integrating it with some of the data from our smartphone-based studies, and we're going to be seeking to enrich this over time. For the group here, I want to talk some about the modeling challenges. Long COVID is a really hard area to model right now, adequately, in my view. Why is that? Well, there's a number of reasons. We don't have very good infection data, right? Anymore. I mean, with rapid antigen tests taking so much of the testing, and many people not even testing with those anymore, it's really hard to be able to track who got exposed to COVID and who was infected and subsequent outcomes. We can use earlier data, but looking at it in the Omicron era is hard. There's this vast array of symptoms guided by these latent classes, these endotypes that are still being elucidated, still being understood. There are these symptom-specific pathways, like I just described, with heart disease or with diabetes or with dementia, that mean that one-size-fits-all characterization of symptoms and symptoms disappearing after a certain times is problematic. And certain symptoms like depression come up again. There's this diversity of biologic pathways underlying things, with these endotypes, with dysbiosis, disruption of the microbiome, neurologic symptoms, both to autonomic and higher cognitive function, immune dysregulation, psychiatric. I mean, we're dealing with this dizzying array of different symptoms. Reinfection, the evidence seems to suggest, wow, boosting of impacts, but right now we need more clarity on that, and how to capture that best is a bit of a catch as catch can job. The fact that we have this diversity of risk factors with all these other conditions, with factors like severity, but also in vaccination and past infection, etc. So we're going to evolve this and the study to try to incorporate work from some of our Indigenous partners. We're very excited about this partnership, which has recently been launched for rollout to about 80,000 people in Métis Nation of Saskatchewan. Should really bring out some of these aspects of under or more vulnerable communities. And then there's been a commitment nationally to roll this out across different provinces, particularly with the Western provinces. So I'd like to end, if I could, with a call to action. You know, we're really witness here to a unique or quite unique historic circumstance in recent memory. The imposition of a high burden chronic disease at the level of some of our biggest chronic diseases we have around. The heaviest burden here falls on vulnerable groups, and there's big inequities associated with that. We're dealing, moreover, with groups of patients who are often, by very virtue of their condition, find it difficult to get effective care, to secure it because of discoordination in the health system, but also because of the limitations of their condition. This disease is preventable, has possible prophylaxis, but you know, it's a very high burden once it has emerged in a way that can yield lifelong disability. The evidence thus far raises as a troubling possibility. There's high structure here that modeling can exploit with savvy approaches. Leveraging that sort of data analysis to find the hidden structure can be important for more parsimonious modeling. And we need modeling, in my view, from the immunological level up to health service, clinical and health service delivery, all the way up to the population level, including but not limited to health economics models. I'm going to be providing the slides here. I've provided, you know, some key references if anyone's interested, some references to Canadian resources and vaccination-related studies, including the tantalizing ones post-infection, but the main ones in terms of protection. And I want to provide my sincere acknowledgements, thanks to the organizers and to the students who helped make this work possible and have helped turn the data from these studies into real insight. So thank you so much. And if there's time here, I'd be glad to answer some questions. Thanks.
Thank you, Professor Osgood.